She has an exceptional eye for detail, and she really does have a sense of what's going on out there. And I'm speaking from experience, because normally I'd be sitting just 2 banks away from her in the office. She's an expert on social enterprise, engagement and social investment in housing, and she really does understand the essentials of organizational and societal change. It's my great pleasure to hand you over to your chair for the evening, Head of Strategic Engagement at Housing 21, Dr. Vanessa Pritchard-Wilkes.
Wow, what an introduction. Thank you, Deirdre. I hope that. So welcome everybody to this webinar. As Deirdre said, it's the second virtual Lunar Society one, and it's my pleasure to be here and to be chairing the event. Deirdre's been through the housekeeping rules, so I don't need to do that. So again, echoing what Deirdre said, it just feels extremely timely to be revisiting this discussion during this pandemic, in which the work of the carers has become invaluable and also potentially dangerous for them. So it'll be interesting to hear the debate about what needs to change. So I would like to welcome Sonia, Bruce and Robin. We'll hear the contributions from all 3 panellists first. I will then invite them to ask a fellow panellist a question, after which we will open up the questions to the audience. The main feedback from the first event was the need for brevity. So can I ask that when asking a question or making a comment, that contributors make their points quite succinctly, please. So our first panellist is Sonia Parnell. Welcome, Sonia. Thank you for agreeing to speak.
Hello.
Sonia is the owner and managing director of Liberty House Care Homes. She has worked in the care sector for 28 years and has extensive expertise in coaching, mentoring, developing, leading and managing people. She has recently received her latest award, amongst many others, a British Empire Medal for her contribution to the community and the care sector. So thank you very much, Sonia, and over to you.
Thank you. I came into the care sector just sort of like by accident. My background is hairdressing and beauty therapy, and I was invited into the care home 26 years ago, yeah, to do some residents' hair. That's when we used the cutthroat razors and the old blue rinse for the hairs. So I got in. It was a care home for people with learning disability, about 15 service users, but they weren't compatible with each other at the time. There was some challenging behaviour and some mild learning disabilities. And by seeing all of that, I just thought that I could actually do it on a smaller scale and make sure that they were compatible. And the passion for what I saw, just massaging and everything else, I fell in love with this group of people, which had a lot to give. So I decided to open my own care home in 1998, and we're still going 22 years now. And I'm a hands-on manager, so I'm a frontline worker. I'll be at work, I do nights, and I take part in everything else that all my staff are doing. I recently came out of isolation with one of my service users. I did 2 weeks, 24-hour care in isolation. Bearing in mind, I've got my own family as well, but I was prepared to go that length because I see these people that I've been working with for 22 years as part of my extended family. I also look after my father-in-law, who's 99, he'll be 100 in 10 months' time. And he got lost down in one stop 2 days ago. So I had the police and everything else on my hand as well to deal with, as well as dealing with the care home. And I think the point about not being recognised for what we do is very, very painful. Going to the shops and have to wait until the NHS go in before us when you're waiting an hour in the queue, and it's NHS workers in first, and then frontline workers can go in behind. There's also the point with, a couple of years ago, the government was thinking of giving us PIN numbers so we can be recognised like the nurses. I mean, I've got 4 nurses in my family. My sisters and my brother's a mental health nurse. And we feel as if we're not recognised as much as they are. I've got my sister who is younger than me. She joined the QE as a nurse, the same time I joined as a as a care worker. And she's retired before me because she was given the option of the pension scheme, which recognised NHS workers that they can actually retire early. I currently have a lady working with me. She's been with me for 21 years. That's a member of staff, and she has to continue working, and she's 60 odd just to be able to get a pension, and she would like to retire, but it's not affordable at the moment because of what we get as funding. I just don't want to go on too much. So.
That's great, Sonia. Thank you very much. That was a really useful introduction and a real insight into some of the challenges that that carers face, particularly in that lack of parity with NHS staff. And it took a while, didn't it, for the clapping on the Thursday to include the carers as well as NHS staff. So that's quite telling. Okay, without further ado, I will pass over to our second panellist, Bruce Moore. Bruce joined Housing 21 as Chief Executive in 2013. Before that, he was Chief Executive for Hanover Housing Group. Bruce's early career was as an in-house lawyer, and he is a qualified solicitor. But he has spent more than 20 years leading change and seeking to improve the provision of housing and care for older people. Bruce has served as a board member for a number of housing associations and charities. He completed his first PhD considering the differences in attitudes and expectation of the governance of the role of boards of housing associations in 2017, and is now studying for a further PhD on the priorities and preferences of residents of retirement and extra care housing. Thank you, Bruce.
Okay, thank you very much. And 1 year on, what a difference. I mean, I think no one could have seen the pandemic and the issues that COVID's had. A terrible shock, and I think it's had a seismic effect on the society, and I think it's going to test and change our attitudes. I think it's, you know, this event, these times, I think will have a ripple effect going forwards. I wasn't at last year's event, and the reason for that was I was at a staff engagement event up in the northeast, followed by a seminar on technology and care. But I understand it was quite a vibrant affair. With a lot of interchange of views, lots of discussion about social care's parity with health, the social political narrative, why we denigrate care and associate low care with low skill. And I think it concluded by saying we needed to raise the profile and raise a campaign around that. And I think one of the things that I think we should be judged on, and I should be judged on as leading Housing 21, is not by what we say, but what we actually do. So what have we done in the last year or so around this? So Housing 21, we've got an inspirational board that really has some really strong values, and we've made a commitment to not only just pay our care workers a national living wage, which is a going rate, but to increase that by 10%. So when it went up by 6.2% this year, we capped on that difference with that 10% increase. We've also moved to more guaranteed hours. So it was a profession that was dominated by 0-hour care workers. And that was probably, when we started this, 80% were 0-hour, 20% were fixed. And we're trying to shift that across. We're about 70% fixed at the moment. But our turnover as a result has gone down from over 30% of care worker turnover to under 20%. That's still a lot higher than our other types of employee. But actually, I think we're hoping to address that. And our quality has also gone up. So we are now at a stage where of our 72 care services, only three require improvement, which is 3 too many, but we have 6 outstanding care services. And we had a campaign earlier this year to actually promote the role of a care worker. It's called Today I Was, and that was about today I was a friend, an entertainer, family, somebody to have a cup of tea, somebody to sing, and to show them how it made a difference, the reason to be proud, the connection, the compassion that our care workers provided. And it wasn't just about the personal care tasks and the practical tasks that people come to. It was about the attitude and the impact that people have. And I think the pandemic has caused us to address our attitudes to care. We are stopping this event at 10 to 8, so we can all clap for care workers, but actually, in the NHS, but actually it's also the cleaners. And I think we should show our appreciation for all the frontline workers who are providing and doing the jobs which actually keep us safe. You know, people like me, you know, we complain about being, you know, kept at home and having to work from home in a different way. But actually it's the people who are still going out to work and doing grafting in subsistence jobs and are keeping the economy and keeping our lives stable that we depend upon. And I think last year we had a representative from Unite who I think was trying to challenge us to change and to make the case for the care worker. I think Sonia's done that very ably already. But actually, we don't have unions in care effectively. Most of our care workforce are not unionised because they can't afford the subs in terms of the extra contribution. So neoliberalism has more or less wiped out that. But we do have everyday heroes and heroines in our care workforce, but we somehow don't quite treat them as full employees. We treat them almost like a resource, a component. They're not the vital part of the organisation that they really are. We have staff events. I was at a staff event last year. We engaged with about 1,000 employees, which is very commendable. But actually, there are another 2,500 which are left out of that. So last year, we decided that we were missing our care workers. And so we went around the country to all our 72 sites and repeated the staff events at each of those. But I think the pandemic has showed us we need to do more. Our care workers are more important. They are the people providing that vital services. In Housing 21, we have had cases, we have had deaths, and it is a really serious issue. But the care staff are taking on that serious role. Sonia again said about being locked in with her carer, providing that caring role. We've had staff doing exactly the same, locked in for 7-day shifts and then again for another 7 days, and really going above and beyond what we would normally expect is really astonishing service. So I think we have to be looking at that. We've tried to keep our catering services going in our extra care schemes. A lot of people have closed those down, and to help that, we said, well, let's provide meals to our care workers on shift. But actually, that's about another form of recognition for providing that difficult times and putting themselves out to do that. But we had a real issue in terms of shielding, sickness, self-isolating. What should we do? We didn't want our care workers to come into providing the service if they had symptoms. We wanted them to stay away and keep our residents safe. But actually, if you're on the statutory sick pay and that's all, okay, we were providing that from without a threshold and everything else. But actually, that's not really enough. And so we had a big debate about what we should do, whether we should make a general thank you payment to our care workers. But we actually said that wasn't the right thing to do. We need to show our values, our staff, to provide them with exactly the same terms and conditions as we apply to all our other staff. So occupational sick pay applies to everybody. And I think the issue is that when we said we'd do that, there were lots of people saying, oh my gosh, what have you done? It will be abused. There'll be a mass absence. That people won't care staff won't behave like normal employees. They'll go off to do something else. And I think that's quite offensive, really, that we actually don't trust and appreciate our care staff in the same way. And I think they've shown us by doing that they are dedicated, they are committed, and they are providing that great service. So I think the pandemic has showed us that the system we're currently operating is fundamentally unfair. I think society, we need to take a long, hard look at ourselves and really judge ourselves by, are we living the values we espouse? It's great to criticise and comment, but actually what are we doing to do that? So the case for change is not just about COVID, it's for good, and we have to really get persistent and actually do something different. It's not political, but actually we have to say, we have to make a difference and push for that recognition and live our values. We have to put our money where our mouth is, our commitment and doing it, because otherwise we'll all stay back and say, oh, it's the system that's stopping us. We have to embrace that and do something different. Thank you.
Thank you, Bruce. I think a really interesting contrast there between a much some virtual clapping going on. Really interesting contrast there from a larger organisation, obviously facing the same challenges, but perhaps with a bit more flexibility and financial viability to be able to provide some additional recognition. So thank you for that, Bruce. I'll now hand over to Robin Miller. Robin is Professor of Collaborative Learning in Health and Social Care at the University of Birmingham and is the Head of Department of Social Work and Social Care. Prior to his academic career, Robin was a practitioner, manager and commissioner and has served as a non-exec director and chair of trustees within housing and charitable sectors. He is a senior associate of the International Federation of Integrated Care, an advisory group member of the European Primary Care Network and a senior fellow of the School for Social Care Research. So thank you, Robin, for agreeing to speak. Over to you.
Okay, thanks, Vanessa. And as you can probably tell from that preview, I'm not very good at settling to things. I've got a low boredom threshold, which is why I do so many things. So I've done some slides because that's what we do at university. We like a PowerPoint. So I'm going to pull out my PowerPoint slides and I'll put share screen. Let me see. Does that work? Let's see. Oh, is that working?
Yes, that's working. Yeah.
Fantastic. Good. Yeah, good. I'll do that. Right. So, one of my real areas of interest in terms of research is about integrated care. And integrated care, as you talked about in the first event, comes in all different shapes and sizes, and is not just integration with health, but integration with education, integration with leisure, integration with criminal justice services, etc. But there's a particular emphasis and drive towards better integration between health and social care because it just makes so much sense. And because so many people in our society and indeed societies around the world have needs, have issues that require the two sectors of health and social care to work together better. And reflecting that, there's been a long-held aspiration for better integration between health and social care. And you can go all the way back to 1963 to find the national initiative which was trying to get hospitals and community health services, which at that point were held by local authorities, to work together. And if you look at the evaluation that was carried out in 1968 of that national initiative, many of the issues that they highlight are very common today, to do with unclear responsibilities, to do with a wish to hold on to organisational resources, and also challenges of staff and staff being able to collaborate and work together better. And this long-held aspiration has had greater emphasis the last decade in England, in the other parts of the UK, and internationally due to our changing demography. So, we've got an aging population, which is in many ways a good thing. We've got more people with multiple long-term conditions, including people in the 50s. We've got more people with complex needs surviving childhood and moving into adulthood, which again, many of those, certainly the first and the third are good things, but actually it means that we've got to respond differently. And that's against the backdrop of financial pressures and concerns about how the system will actually cope and provide enough resources. In the last 10 years, and England's really at the forefront of this, we've had numerous initiatives to promote integrated care in policy and practice. We've had national integrated care programs, we've had the pioneers, we've had the vanguards, we've had health and wellbeing boards, we've had SDPs, we have had integrated care systems currently being launched. So numerous different initiatives. And some of those have been focused more on the assessment and care management side of it, but some of them, in particular the new models of care around care homes and trying to wrap around primary care services, are more focused on care settings. So the need for integration between healthcare professionals and frontline care services has been recognised to some degree. And whatever form of integration you're looking at, there's a strong recognition from research and practice that the workforce are central to that. You can have the most fantastic set of financial incentives, of policy performance measures, of visionary statements, but actually if you don't support, encourage and change the way that the front line work and collaborate, you won't make any difference in practice to the lives of people and their families. And the other thing that comes out very strongly in that is that the health and social care workforces are so different in terms of the level of professionalisation, in terms of registered professionals, not people being committed to the jobs, in terms of pay, as we've heard about already, in terms of recruitment and retention, and in terms of the kind of ethnic mix and diversity of the workforces as well. So they're very different contexts and very different workforces we're trying to bring together. And I think all of us who've got an interest in social care, either as somebody with lived experience or somebody who works in it or somebody who studies it, has been really quite appalled, I think, by the initial response of the English government to the social care setting. And right from the off, the initial emphasis to the pandemic was on protecting the NHS and its staff. And clearly, all of us want us to protect the NHS and its staff, and we recognise the importance of maintaining capacity in intensive care and so on. But that was to the detriment of the people who live and work in the care settings. And there's increasing evidence coming out that actually the government were advised in early 2020 that people within care settings were going to be the most at risk of catching this disease and being really affected and potentially dying of the disease. But despite that, the government did not respond to those concerns. And the priority was very much on freeing up hospital capacity through getting people out early, including discharging people into care homes, and avoiding admissions, including admissions from people from care homes. So right from the off, the priority was on hospital capacity, on hospital services, at the cost of people who are living and working in care homes. And similarly, diagnosing people within care homes in terms of COVID-19, and crucially and bizarrely, people being discharged and not testing people being discharged to see if they had the virus was not seen as necessary, which is really quite difficult to understand. And similarly, we've seen, play over the last few weeks that testing and the protective equipment for staff in care homes was delayed, and still at this point, many care homes are reporting difficulties accessing with the quality of the equipment they receive. And just one very powerful artifact was the headline statistics on number of cases and deaths, which did not include care settings, and does now, but didn't for so long. And it's really quite disturbing, I think, particularly against this backdrop of 10 years of a real drive towards integration, of the sectors being seen as equal importance and part of the same system. And I think what I've been interested to put out for discussion is, why did this happen? So that's the reality. I think we'd all accept that, but why did this happen? And three things I thought of in preparing for today was, first of all, in our time of crisis, we generally retreat back to what we know best, to what we have been brought up as seen as most important. And in many ways, we like to go to what we feel most confident about. And it could well be that the advisors who were talking to the government and the government ministers just feel more comfortable in the health setting. When it's so much uncertainty, when there's so much stress and anxiety, that's what they go back to, because that's what they have always seen as more important, and what they know most about. The second question, the second factor could be, is it because healthcare is still naive about what the care sector actually is? The breadth of providers, the breadth of settings, the breadth of people who are supported, the complexity of need within people within care settings and the vulnerability that presents, and also the huge contribution that the care sector and its workforce make to general society. It's not just caring for a few, it makes a difference to local communities too. Or, and perhaps most troubling, is, does it reflect a negative bias towards the care sector? As Bruce mentioned, there's still some very stereotypical views about care workers and their motivation and dedication. Does this reflect a fundamental neglect and bias against the care sector and what it does? Or perhaps it's a mixture of all those. But all those are very concerning issues, aren't they, when we're trying to promote a more integrated world between health and social care. So in terms of what that means going forward, because at some point we'll come out of this difficult crisis, the first thing is that belatedly, we've at last started to recognise the contribution of the care sector. And so often when we hear the care sector in the media, what we hear about is financial burdens. We hear about carers being, having to look after such vulnerable people and give up working lives, etc. What we've heard recently is that the care sector is incredibly powerful, incredibly dedicated, incredibly skilled. And that is something that we should celebrate and hold on to. Another point I would say moving forward is that, again, we often get these divisions between private, voluntary and public providers. That's not being emphasised. What we're talking about is the care sector. And I haven't got a sense of any sort of negative comments or blaming of private industry as opposed to the voluntary or public providers. And that's really important if we're going to have a common message. So this could provide a really good springboard for better integration, recognising the difference, but also recognising there's an equal contribution that we all require. The public mood is now supportive, and could this finally lead us to have the context in which adult social care funding is finally reviewed and crucially implemented? Because without that, it's very difficult for the sector to have confidence, to have security, and therefore be able to negotiate with health as an equal partner. And finally, I think there is a dilemma for social care. I think a number of us were pleased that NHS were getting clamped on a Thursday night, but also frustrated that social care wasn't there. But equally, sometimes as social care sector, we ask for that, don't we? Because we say, well, we're not the NHS, we're different to the NHS. And we've got to try and work out that conundrum in our head of how do we get the affection that people have for that branding, but equally have our distinction as well. So I think it's been a really terrible example of integration not working for the first few weeks of this pandemic. I think belatedly things have tried to catch up, and it's how we use that as a springboard to go forward to make sure that social care has that proper equal recognition with healthcare that we also desperately need. And that's me.
Thank you very much, Robin. That was a really interesting. Sorry. I should clap as well, shouldn't I?
I think you should.
Sorry. Thank you, Robin. Really interesting insight there into the government response, and also emphasising the lack of parity between the NHS and social care. And you touched on there as the care being seen as a burden, and that's something that we did discuss last year as well, in that actually that rhetoric needs to change. So we see care as an investment rather than a cost. I was on a call today and learnt that there were 6 different government guidelines issued for use of PPE in care homes, which just led to mass confusion as well. So yeah, really poor handling in some circumstances. So thank you, Robin. A format that we tried last year as well is to get each of the panelists to ask one of their fellow panelists a question. So I hope you prepared for this. So I was going to go in the order of the speakers. So Sonia, did you have a question for either of your other 2 panelists? Or Sonia, I think you need to unmute yourself.
Yes, it was a question for Robin. I have experienced the difficulty in working with health, whereas health has not wanted to recognize if a client have had health issues regarding funding. Have you come across that if there's a dual funding and that one person didn't want to take the responsibility?
Oh yeah, definitely. No, it's very, sadly, it's very, very common. And I used to work as a commissioner for service to people with learning disability. So I've spent many unhappy hours negotiating with my colleagues on the other side of the table to identify if somebody's need was 67% or 69% healthcare or social care. So it still happens, and it's still common. And even sometimes where you get a pooled budget where you put the money together, it doesn't necessarily release the tension, because people are often still got an eye to how their money in the pool budget is being spent. So it is a real issue. And I think there's a couple of things for that, though. I think partly people can sometimes be reluctant to share resources because they're anxious, because they're worried about their own demand and their own pressures, and they're feeling that they can't cope with their core responsibilities, and therefore they're not willing to share somebody else's responsibility. So that can be one thing. The other thing is that people just don't necessarily understand the impact of their resistance to share resources and skills with somebody else on the person with lived experience and their family. And that's part of the education that we have to do to get people to understand how all these parts of the system connect up together, how they're all part of this whole. And then I think people will find it, have more confidence and less anxiety about sharing, and also recognize that morally they have a reason to do so.
Thank you, Robin.
And keep short. That's what you said, didn't you, Vanessa? I was in full flow there, and I thought, hey, this is great. And I thought, no, keep short. Vanessa said.
Wow.
So,
Thank you for adhering to that, Robin. Much appreciated. So, Bruce, do you have a question for one of your fellow panelists?
Yeah, I think I can direct mine at Robin as well, but I think it does pick up the messages that Sonia raised, which is I think both of you have raised the issue as the divide and the unequal status between health and social care. But I'd put it to you that actually is that more a symptom of a general sort of super narrative that prioritizes a medical model of how we think about things? And actually, is it more that we should look at and says that age and other conditions can be fixed? Because actually, rather than look at our values to say, how can we be more compassionate about our approach to seeing the whole person and not just the medicalized condition? And I think, just as what Robin was responding to Sonia's question, I think the fundamental thing is that however intense your medical needs are, they're free under the National Health Service, and that's great. But actually, the social care has to be rationed, funded, and everything else, and that's driving us down to, not wanting to pay for, because we see that money coming out of either local authorities' pockets or our own pockets, and that drives a different attitude. So, is it more of a societal values issue rather than just addressing this divide? We'll keep on talking about the symptoms rather than the cause.
yeah. So, Sonia, do you want to go first with that?
Yeah, I think it's more talking about the symptom than the cause, because I believe that the emotional side has to be addressed. So when somebody comes out of hospital, at the moment, what I'm going through, it's taken about 8 weeks, and we've been battling with health to identify a particular service user that his needs and health was more outweighing the needs on social care. And it was all about the funding. We battled backward and forward just to see the social workers battling with me. This person needed a one-to-one support, and health didn't want to give him the one-to-one support. I battled backward and forward until at the end of it, they realized that the person was only receiving half of the involvement in health than he needed. A majority, 99.9% of his care was needed from health to support his social care needs as well as his health needs. So I believe that they don't address that, and I had to fight for that. And I'm also fighting for another 2 clients, and I've been fighting for that for 2.5 years with the social worker, just to identify. I mean, CHC, it's something that I never knew about. And when I did ask about it and realized that 3 of my clients was identified that they needed continuous health care, and we're still fighting for that. And just getting the funding to support them. What I had to do is remortgage my house to help to support twice, to help to support the care needs that we needed to put the staff in.
And that's a situation everybody should be put in, isn't it? So
yeah, that's extraordinary. I mean, just extraordinary commitment, Sonia. I mean, I think all of us must just be so impressed and honoured to hear you talk about that. It's incredible commitment. I mean, I think Bruce is absolutely right. It's more than just but it's more than just arguments about funding and about professionals not working together. It's a much deeper philosophical issue. You're right about the medical model, the traditional medical model and the traditional social model. It's also about how society values people and what we see as important. And most of us access healthcare services at some point in our life. They're often there when we're at the most challenging times, or we're having children, or we've got elderly parents, etc. But social care, well, sometimes we don't have contact with social care. We do hear about social care. It's with people that we might not see as being very, sort of worthy people, or people who've led to their own issues. Therefore, they need this support. So I think there's all that going on in the background. I would have a bit of an issue, though, I think, with the idea of the medical model and the social model currently, which would be good to debate. So one, I think healthcare has moved on. I think healthcare now is recognising that social issues, social context, the need to be person-centred in the approach is relevant to healthcare and to broader outcomes. So I think healthcare is moving on. And I think there's also a danger if we keep up the idea of that's the medical model and this is the social model, it's not going to encourage doctors to actually embrace this new way of working. Because if I was a doctor, I'd be saying, oh, you're basically saying that I'm old hat and I'm outdated. Well, I don't know if I agree with that, and it could turn people off the debate, when perhaps what we need is a new model of healthcare or a new model of medicine, do you know, that actually gives them some skin in the game and some encouragement that they need to change their practice.
I saw a couple of nods and people clapping during that comment. Is there anything that anybody wants to add at this point? Yes, Pete?
I think you can hear me.
Yes, can.
Yeah, very good. So I'm going to say a bit more than we did at the meeting 2 days ago. My background as a geriatrician, but also chair of joint planning in the past. And I was a bit late because I'm writing a bid at the moment for looking at the pathway needs of survivors of COVID. And I also, for 20 years, ran an Excellent Care Award. And there have always been very good models of integration between voluntary and agency services that we don't learn from. And one of the worries, I think, for me, is how do we actually take things that we already know that work, and maybe joint aid stalls might be one, and actually translate that into service delivery at the moment during this crisis. I could go on, as I say, this is clearly an area I'm very interested in, but I think we often look at the financial, the budgetary and the legal boundaries between the agencies as a block. But I'm actually going to attack a bit the academic sector, because why have we got social care university departments separate from health departments? Why isn't there a proper college approach which brings the two together and helps drive change?
Robin, did you want to come back on that? And I'm also aware that you still have the opportunity to ask your fellow panelists.
Oh, definitely. I'm looking forward to asking my question. So, yeah, so I think that's an interesting one. And in some places in the UK and internationally, social work, which I guess is the strongest social care profession, is based within a health faculty. So it does happen in places. I think you can argue either way. Actually, it's interesting. So clearly there needs to be better collaboration between academics from a social care and a healthcare background. And I would say over the last 10 years since I've been at the university, that has got better. When I started, we would go quite often to colleagues in the College of Medical and Dental Sciences, and they weren't mean or rude, but they just weren't that interested. But now they're actively coming to us and saying, we recognize that social care is part of the system. We know we need to get you on board to get the funding. So I think it is changing. But with integrated care, you can argue that what you need is a really strong set of professions. And you could say that actually what you need is social work to have a really strong identity based in the social sciences that then enables them to collaborate on an equal footing with healthcare. And if you put social work in a large College of Medical Dental Sciences, they are a really small player in a massive health field. So there is one argument that says, actually it's better to give them the confidence and the training separate, but give them the skills to then collaborate together. So I'm not saying that's right or wrong, but there is an argument that actually that could be the way to do it. And whatever we do, we certainly need to educate people more together. I'm completely committed to interprofessional education, in the qualifying, in the post-qualifying programs, in their CPD. We should be doing that together, not in silos, I would say.
Can I come back?
Yes.
The model I worked in, we had monthly joint meetings. Social workers were employed within health, and some local authorities have withdrawn them from that. And we used to have a panel, basically, to look at the health social care divide. And some regions managed to reduce the bed blockers down to nearly zero. There was this perception, which still exists, doesn't it, that you are medically fit for discharge. And I was a geriatrician, and without actually understanding, that doesn't mean you are fit for discharge, because social care support, all the other things haven't been set up. And there is a lot of work that's gone into that and the readmission rates. But, in some ways, I don't think we need to reinvent. And I suspect Peter, as a general practitioner, has also seen joint work, which has depended very much on the people at the ground level breaking the rules and talking to each other, that really assists. And the voluntary sector, Age Concern, and I used to be chair of Age UK in Birmingham for quite a long time, did have joint models that actually supported both health and social care in delivering people to appropriate accommodation. And also we did home visits with our social work manager, I did, and made the bed at home, so that so lots of things don't seem to have stayed in the institutional memory. I disagree quite strongly, despite being boasting again, chair of the West Midlands Socialist Health Association, that this is purely a financial and resources issue. There's a strong attitudinal issue, as you said earlier, in not recognising where joint memory and joint philosophy actually exists. And at the moment, I'm looking at that also retirement villages, because within the Birmingham system, they don't get the support that care homes get, because their residents, I am told, are much fitter than care home residents. And as my daughter runs the Hagley Road retirement village, I think that's partly true, but many of their residents have the same needs.
Thank you, Peter. If yeah, the other Peter, would you?
Hi, I'm the other Peter. Hi, I'm the retired GP, as it were. I worked with Peter Mayer for a while, many years back, and he taught me a lot. So, but my feeling here is that there is a discord, I think, between. In fact, Robin brought up the idea of silos and such like, and I think the NHS and social care system has been in silos for quite a long time, and we've been accepting that because we always have thought, well, medically, you know, we can treat a patient, but social care as well, it's a soft end of the issue, so we tend not to attach much importance to it. Now, Peter brought up quite a few points there, but there's been mention of the holistic approach. Now, I think if we put, again, this is probably blue skies thinking, but if there is a certain amount of holistic approach nationally, politically, financially, we might end up with not just an NHS, but an NHSCS, the National Health and Social Care System, which hopefully will be more cohesive. But I think it requires a lot more. I mean, we're all very much of a similar mind, I'm sure, here talking, but there seems that we need to have some sort of drive to get people up top being able to say, look, okay, we need to move along with this. Well, I won't talk about money, but we all know that the system needs money. But at the end of the day, we need to have that political will and push to get a holistic system in line. Medical school is great, but again, as has been said, we need to have social workers, social care system running alongside things there, because that's where most of the care is done in the community.
Thank you very much. Stephen, did you have your hand up there, Noah? Oh, you're on mute, Stephen.
Yeah, I've got a few things to say, but I'm happy to wait until Robin asks his question of others, and then you can invite me in when we get to the general discussion.
Okay, that's great. Thank you. So, Robin, at long last,
no, that's great. Thanks. I mean, clearly, I'd realised as Bruce how he's got the energy to do a second PhD, but I think that's probably a discussion for another day. But I guess for Sonia and Bruce, I think we've talked a lot about the health and social care interface, but what about within providers then? Because we sometimes describe it as a care market, and a market implies we've got different organisations fighting against each other for resources. Have you felt during this difficult pandemic time that the care sector has come together across private, voluntary, public sector sort of boundaries and are really collaborating together, or is that something that you found has not actually happened in practice?
Who would like to respond to that first? Bruce, you look quite keen to respond to that.
Yeah, I have a go. We're not good at collaborating, I don't think. We are all in our little pots. I think, that's part of the equation, that social care, I mean, the health service is also lots of components and lots of parts, and there isn't a one big thing. There's lots of elements to the health service, but they all brand themselves and they all link across. And I think there's a social care narrative that's been really quite positive with the pandemic, and I'm hopeful that with some push that social care narrative can develop. But actually, we are very fragmented. The social care sector is incredibly fragmented in terms of how it operates and how it's regulated and how it's reviewed. And that's great to some extent, because it means that Sonia's care home and Housing 21's extra care and all the other domiciliary and care providers can all sit alongside each other and many things. But it does mean we don't have a combined voice. So we have collaborated. We had the challenges around PPE early on, when the health sector, came in, swamped our normal supply chains, and we were scrabbling to get stuff. Now that's been restored, and I think there's a sense of direction and balance. But we did help out some local charities when we were massing PPE in church halls and our office and other places to resend it on, and we did help out a few other charities. Let us know, but there's no infrastructure to connect up. I think there are forums, but they're more campaigning elements rather than integrating service elements. So I think it's part of the structural element, that the way the social care sector is, that it is very hard for us to speak with one voice sometimes, I think, or collaborate and connect our services, because they are quite fragmented.
Thank you. Sonia, did you want to add to that?
Yeah, I do believe that there was a clear element of competition. I mean, I did a talk for Birmingham City Council when I actually tried to raise this point, to actually involve people to collaborate a bit more, because whatever knowledge I've got and information I've got, I share at these forums, and my experience myself, I share at the forum, and I try to bring over with a presentation to say that care is not a competition, because we can't actually look that if we're all caring, we need to be on the same level, because we've got one aim: to get that person better and to support that person's health and well-being much better. And I do believe there was a competition running at one point. But like Bruce have just said, we've helped other care homes, because I'm a small care home, but I do buy my stuff in bulk. And when I realized that some people didn't have PPE, our suppliers, because we're regular with our suppliers, and they supplied us with PPE. There was a point that we couldn't get stuff, but we didn't really need as much as we did, so we helped other care homes. Birmingham City Council actually set up a line that you could actually put yourself forward if you wanted to share staff for those care homes that didn't have enough staff at the time, and wasn't showing any symptoms. But we haven't been down with any of our staff or service users. I decided to make that conscious decision of closing 2 weeks before the government closed, the pandemic came about. But we have been sharing stuff, and I think it's sort of opened our eyes that we do need to come together. So we have been corresponding with other care homes just to see how they've been managing.
That's great. Thank you, Sonia. And I think it is that point, isn't it, that let's hope after all of this that the social care sector can come together a bit more and perhaps have that voice that it needs, certainly if we're going to get parity with the health sector. We don't actually have any questions in the chat room, and I think we're a small enough group to kind of wave our hands. So Stephen, happy to bring you in. I know you had some comments to make.
Yeah, there's a problem with the chat room. I'm not quite sure what it is, because it's listed as David Private. That's the only, and you can only write messages to David, I think. I don't know why that is, but that seems to be the case. Oh. I have a sort of a thesis, which is that the real problem is to do with different models of providing public service. There are kind of two models: the universal service, which means everybody gets it, and it's paid for through taxation. So it's progressive in the sense that if the taxation system is progressive. And then the other model is, why should, you know, rich old age pensioners get a free TV license? Let's have a targeted model whereby services are only provided to people who need them. And what we've got is the health service, which is universal, and a social care service, which is targeted.
And organizations in terms of their governance and such like. And as a result of that, I've been supporting during this process with getting PPE out to various care homes, and the smaller ones in particular. And it was really interesting because the pre-COVID, there's always been this kind of we need to protect our turf mentality. And what I found interesting was that there still was a dynamic of protectionism at first, but now the care organizations are coming together mainly fueled by financial constraints, because they need to buy in bulk in order to be able to get the PPE. But it was really interesting that there was still that dynamic of protectionism in the beginning. And yeah, so, and the second thing was in relation to the point that Kath made. I mean, I've been reading about care staff who are really at the end of their tether, people who are saying that they don't enjoy their job anymore. They're terrified to be going into work in any event, and they're traumatized now, far less for after COVID is over. And I think it's really key that organizations are supporting their care staff in relation to their mental health needs, because they're dealing with such incredible emotional and personal pressure whilst trying to do their jobs in really, really difficult and trying circumstances. So it would be fantastic if the mental health elements, whether within the NHS or privately, is part of that integrated support for the social care sector, to help to support them with their workforce in a meaningful way.
Thank you, Deirdre. Thank you. Robin, you look like you might have a question or comment.
Yeah, no, I just agree, and I think some of the people in the care, the staff working in the care sector, and indeed staff working in the NHS, I mean, there's a real danger they could have post-traumatic stress, isn't there, from the amount of sort of death and sort of distress that they've seen during this time. I think we do have to pick that up. And just to respond to Cath's point as well, I've got a colleague, Harry Ferguson, who's doing a study of child safeguarding during the time of COVID, when a lot of social workers are essentially trying to keep an eye on and interact with children through social media and through technologies, etc. And one of the things they highlighted is there's a whole set of issues with that, was that they were sitting in their front rooms engaging with children who weren't safe, and usually there's a boundary between what they do at work and what they do at home, and whether it's getting the bus, driving home, shutting the office door, there was a space there between, but that wasn't there now. And it was that, and there's the psychological elements of that, of your work and your home life just being so woven together, I think is another element that will come out of this that we've got to be mindful of.
Absolutely. Yes, Kath, would you like to come back to that?
Just following on from that, Robin, as well, and what you find is that people are absorbing all of that, aren't they? So they're absorbing looking after people, they're absorbing people passing away, trauma, that type of stuff, and I'm involved in a number of research studies at the moment, sort of looking at mental health during COVID, and how people are responding and reacting. And what they're saying is that there's going to be key themes that will come from this, where there will be sort of key areas such as bereavement, counselling will be required, anxiety in terms of people being afraid to go out and to start to normalise those processes again, and definitely where key workers are absorbing all of that to the point that it will come out at some point, and what will that some point look like, and when will that be? So it's really interesting. It's really interesting.
Thank you, Kath. just got about 5 minutes left. Has anyone got any questions, comments that we haven't covered yet? Yes, Sonia?
Going back to what Kath was saying on the mental health side, as a hands-on manager and a provider, I find that we were inundated with questionnaires from the NHS, from Care Quality Commission, from Health and Social Care, and this was every day, plus dealing with my staff, the anxiety from the staff. I found myself was in my office one day and just sitting there, and I just cried because the overwhelmingness that everybody was expecting from myself, I just couldn't give it. What I did was I actually gave staff days off and covered them myself, covered the hours myself, and gave them vouchers. I went to Boots and I got vouchers for them as a frontline worker. They gave me the vouchers. I paid for the vouchers for them to have like pampering nights. I tried to do as much as I could to support them, but I find that there was no one there for me. And I find that I was getting emotional, especially on the last 4 days of my isolation, of the 14 days that I was in isolation with one particular client myself. And I was getting low, lonely, and it was affecting my mental health. Plus, I was still working while I was in isolation because I had to keep it, because next door was the care home and isolation was the following. Next door we had some flats that we use as part of our contingency plan, and that's what we use. But yeah, mental health is an issue, and also for the workers, but also for the provider, the registered manager. I think that's something that needs to be looked at and will affect us later on.
Yeah, I agree. I think your staff are very lucky to work for you, Sonia. You certainly do live your values, definitely, in how you're looking after them, and hope you get the support you need as well.
I'm very lucky to have them. They're actual brilliant staff, brilliant staff.
Brilliant. So we've just got a couple of minutes now. I don't know if the panelists perhaps want to just say a concluding remark reflecting on some of the conversations that we've had this evening.
Can I just thank them all and apologise? I actually have to sign off now, but thank you, everybody.
Thank you, Clive.
Thank you.
Bye. We'll go in reverse order. Robin, did you want to?
Well, just to say, I think it was a really helpful and interesting discussion, and I think all of us are just craving, aren't we, for something good to come out of this terrible pandemic, and perhaps an equal footing for social care, new collaboration between health and social care, and a new collaboration between different providers would be something that we'd be able to achieve. And let's hold on to that and hope we can get somewhere towards it.
Thank you, Robin. Bruce, did you want to say a few words?
Yeah, so I think we've covered very much the need for social care and health to integrate and the valuing. But I would probably have a general plea for society to think about those who do the frontline jobs, the difficult jobs, the tough jobs, and the subsistence jobs, that we actually need to value them more. I think we have a very an unequal society is a very unstable society, and I think this pandemic we're all in it together. That's the ethos we have. We need to live that when we come out of it. We're great clapping, but actually if we just clap and then ignore it and go back to our current ways of behaving, then that's a missed opportunity. So I think we have to then follow through, not just show our appreciation, we have to act on it as well.
Thank you, Bruce. And you raised something there about the inequality in society, and we are seeing how COVID is affecting different sections of society as well in very unequal ways. So we obviously don't have time to talk about that now, but I think it has highlighted some of the inequalities. Sonia, do you have a final few words to say? You just need to unmute yourself, Sonia, please. Thank you.
Sorry. Like Bruce and like Robin, I also believe that, yeah, we need to start looking at the academic sector coming together with the practical sector to see that we're all one, as we're all human beings, and all areas of work, no matter what level, need to be respected, and we cannot actually survive without the other.
Thank you. I'm not even going to pretend that I can summarise this debate to any great extent. We've covered such a vast array of areas, and hopefully Deirdre might have been taking some notes. But I think one thing that's come out very strongly is obviously the integration that's needed across the NHS and social care, and the lack of parity within the workforce there, both in terms of professionalism, pay, etc., and also career paths. A bit of a plea to take something positive away from this, so looking to the future, perhaps looking at our successes rather than the failures, and actually what we could do to make things better, and a recognition that now is possibly a good time to shake things up a little bit and actually do something positive, and to try and stop the long existing silos between health and social care to exist, and to remember it's actually about that person. It's not about fixing, it's not a medical model to fix that person. We should be looking at the entirety of that person and the holistic care and support that they actually need. So bang on 10 to 8. I would just like to thank our participants again, and I will clap this time. So thank you to everyone who spoke on the panel. Thank you to the audience for all your insights and your questions. And I will leave it to Deirdre to formally close the event.
Thank you, Vanessa. On behalf of the Lunar Society, I would like to thank all of the participants and all of you for making this such a very robust and interesting discussion. And I really do believe that this is going to go beyond discussion. There's a lot of action that can occur from this talk. I'm certainly not a person who believes that we should just talk about things. We need to catalyze into action. So I think a big part of even getting that action going was having the smaller organizations represented by Sonia, the larger organizations represented by Bruce, and the academics in the virtual room. And it would be amazing and wonderful if the collaboration that started here today can move forward for the future, post-COVID, certainly, and we can have that integrated model in action. So I'd also very much like to thank, and I would ask you all to please join me in thanking Vanessa for being such a fantastic chair. We really appreciated your wonderful chairing skills tonight, Vanessa. Thank you so very much. And it just leaves the last thing now for me to ask you before we go off to stand on our balconies or in our front lawns or even in your sitting room to clap for our carers, our key workers, those integral staff who are risking their lives to keep us all safe. So if you could join me in a clap, I'd be grateful.